Hey everybody, and welcome back to another episode here at WhiteBoard Medicine. We appreciate you checking it out. Today we're going to be talking about medical screening, specifically colonoscopies. So we'll be diving into the guidelines for colonoscopy screening. We'll talk about the rationale for screening, why we do it, detection and prevention. We'll talk a little bit about polyps, when to get surveillance exams. We'll talk about the procedure itself just a little bit. We'll talk about risks and complications of the procedure, some special considerations, alternatives to colonoscopy screening, some clinical pearls, and we'll go from there. For those of you new to the channel, this channel WhiteBoard Medicine. As a friendly reminder, none of this is intended to be acted upon as medical advice. Please listen to the end of the video for the full disclaimer. Also, some shameless plugs. We have a Patreon page where we upload all of our study guides and practice questions for these videos. You can find them on there. We also have a weekly newsletter and a podcast and YouTube channel, so we'd love for you to check some of those things out if you're interested, all linked in the episode description. Shameless plugs done. No further ado, let's dive in. Colonoscopies. So, guidelines for colonoscopy screenings, this has evolved over the last, time all blurs together, 5 or 10 years, something like that, where we're pushing the screening to earlier ages. And some of the rationale for this is we're unfortunately seeing an increase in GI cancers in those that are younger. And that's probably not just because we're screening more, although it could be. It may be because there's something else going on leading to younger folks getting GI cancer. So tough to say for sure, but we are starting to screen earlier. The organization we tend to follow the most is the USPSTF. Oh, goodness, we knew what that meant at some point. United States something task force. Someone can let us know in the comments. But their recommendation is that we begin screening actually at 45 years old now, okay? And then we go until at least someone is 75. When someone's between 76 and 85, it becomes individualized, where you kind of talk about a risk-benefit. And the rationale there is not because you don't get colorectal cancers when you're in this age group, but the duration of life left as compared to the diagnosis and management of colorectal cancer starts to be shifted a little bit. So, some folks when they're 83 might not want to go through all the prep and risks of a colonoscopy because they're saying, if I got cancer, I just kind of want to leave it be. I just want to let it take its course. I don't want aggressive care. So between 76 and 85, it's individualized where you talk to your physician. And then most organizations in the USPSTF do suggest when you're over 85 years old, you stop colonoscopy screenings for that same reason that you most likely wouldn't be able to tolerate some of the therapies. Now, this might change too, and this is just what the USPSTF says. This is not necessarily a hard and fast rule. And as we start living longer and longer and quality of life is extended to older and older, this might change too. So that is that organization. The ACG, the American College of Gastroenterology, recommends starting screening at 50 years old, with the caveat being if you're African American starting at 45, so they have kind of 5 years later. And they recommend repeating every 10 years if normal, which is a pretty common recommendation, okay? ACS recommends starting at 45 years old, repeating every 10 years. And then if you have a family history of colorectal cancer, the recommendation is you start 10 years before the earliest diagnosis in a relative, or at age 40, whichever is first. So if you have a relative who is diagnosed with colorectal cancer at the age of 30, you should be starting your colorectal cancer screening at 20 years old if they were diagnosed when they were 30. If they were diagnosed when they were 40, you should be starting it at 30 years old. Okay? Repeat every 5 years in higher risk groups. So I think most folks kind of get this recommendation, starting at 45 years old, repeating every 10 years if it's normal. And we'll get more into what normal is and if they have findings, when do you repeat and all that kind of stuff. So the rationale for this is that colorectal cancer is the third most common cause of cancer and the second leading cause of cancer death in the United States. So it is unfortunately very common. And we know that early stage detection vastly improves 5-year survival, right? 5-year survival can be greater than 90% if you have localized disease. So if we find it early and we can do something about it early, you have a really good chance of, surviving for a long time. Most colorectal cancers develop from benign adenomatous polyps. So we're going to talk about what that is. And they usually start from those and then develop into colorectal cancer over 5 to 10 years. So if we can, again, identify this early and get rid of the polyp, removing polyps interrupts this progression. You could prevent it from even getting to cancer. And if it has progressed to cancer and you detect it early, you can do a lot about it. So detecting polyps early and getting rid of them interrupts this cycle of becoming cancer. And if it is an early cancer already, we can do a lot about it in early stages. There is some risk benefit and cost effectiveness benefit. That's why colonoscopies are recommended every 10 years. It's felt that that balances the procedural risk. We'll get into the risks a little bit more, but colon perforation and bleeding are two risks against the cancer prevention benefits. And it's not 10 years for everybody, and we'll talk about those groups coming up. There's a population health impact. Widespread screening has reduced colorectal cancer incidence and mortality by actually 30 to 50%. So that's a huge number, right? Decrease colorectal cancer incidence and mortality by 50% in those that get screened. So you need your colonoscopies. Get them done. Unpleasant, but get them done. So detection and prevention. Well, polyps are one of the things we're looking for. And when it comes to polyps, there's different kinds of polyps. The two big branches are adenomas and then serrated lesions. And adenomas are broken up into tubular, tubulovillous, and villous. And adenomas that have villous features or are big, greater than a centimeter, have higher malignant potential, higher risk of progressing to cancer. Serrated lesions account for actually 15 to 30% of colorectal cancers if they kind of fall into this category. So larger lesions, lesions with villous features, and serrated lesions all can be a higher risk. When you do see a polyp on a colonoscopy, you usually will get a polypectomy or polyp removal. If it's small, they can just use a cold snare to take it off. Sometimes if it's larger, you need to actually kind of resect it out. And then if it's a flat lesion, this is outside my area of expertise, but there's endoscopic submucosal desiccation to get rid of those flat lesions. If a lesion is detected, surveillance picks up. It's more frequent. So if there's no polyps, as we said, you get a repeat colonoscopy every 10 years. If there's 1 to 2 small tubular polyps, right? We said tubular is more likely to be benign. Villous is more concerning. And we said smaller lesions are more likely to be benign. Larger lesions are more concerning. So if there's 1 to 2 small tubular lesions, usually you'll say repeat colonoscopy in 7 to 10 years. If you have 3 to 10 lesions or any lesions greater than 10 millimeters or 1 centimeter, or any lesions with high-grade dysplasia or that are villous, repeat in 3 years. 10 adenomas, consider more frequent repeats, and really should see a specialist at that point to try to figure out if there's anything underlying this. So the more concerning the lesions, right, greater than a centimeter, anything with villous features, or increased numbers, all translate to increased frequency of screening, which makes sense. Those are higher risk groups. How the procedure works, we're just going to go into a little bit if you haven't had it, or if you're going to have it soon, or if you haven't done one, if you're in healthcare. You need a bowel prep. You need to actually drink polyethylene glycol or sodium picosulfate. These are large volumes of liquids that kind of help with osmotic diarrhea and help you clean your colon out. And it's quite literally to get the stool off your colon so that the person doing the colonoscopy can see the colon walls. Clear liquids the whole day before your prep. Yes, it will cause diarrhea. You want it to end up causing clear diarrhea after you've been quote unquote cleaned out. Anticoagulants and antiplatelets per protocol with your physicians, all that good stuff. So when you do the colonoscopy itself, most patients get moderate sedation. A lot of times this is midazolam, also known as Versed, and fentanyl, which is an opiate. And this is kind of like puts you into twilight. Whereas sometimes you'll actually get deep sedation with propofol by an anesthesiologist, or some endoscopists, some GI docs who are trained to do deep sedation can do it themselves too. The first phase of the procedure is the insertion phase. Most patients lay on their left lateral decubitus, aka they're on their left side. The colonoscope gets inserted into the rectum and insufflated with air or carbon dioxide. So they actually insufflate the colon, and then they start to progress under direct vision, looking at everything. They identify landmarks. They progress from the rectum to the sigmoid. Sigmoid goes into descending, right? Because rectum and the sigmoid. I'm just going to draw a colon quick. So this is the rectum into the sigmoid, into the descending colon, transverse colon, ascending colon. And then the cecum is usually this part here that goes into the small bowel or the ileum. So this is cecum. So the colonoscope is a camera, quite literally. It's entered into the rectum. It goes into the sigmoid. into the descending colon, into the transverse colon, into the ascending colon, into the cecum. And they do direct visualization. They then withdraw it, and the withdrawal phase is deliberately slow, where they're pulling back the colonoscope, and they're doing it so because they're looking at the mucosa again. A lot of times greater than 6 minutes is recommended. And the colonoscope has kind of this water mechanism to clean walls so they can see things well, and they're really looking to make sure they're documenting and getting every single lesion that they might see. Post-procedure is mostly recovering from the sedation rather than the procedure itself. Most patients are able to kind of advance diet and all that, depending on what they had done. And then the pathology, if they had to take a lesion off, takes a couple days. So risk and complications, colonoscopy is very, very safe. Most quote a risk of perforation, where you actually perforate the colon, at less than 0.1%. Right? This is very, very safe. If you do have it, you might need something like surgical or endoscopic repair. If they do have to do a polypectomy, they see a polyp in the colon, they have to resect it. You can have post-polypectomy bleeding. They do a really good job of decreasing the risk of this, but it is possible. If that were the case, you probably need another colonoscopy to help staunch that bleeding. There's sedation-related complications from the moderate sedation. This is a separate thing from the colonoscopy itself. And then there's this entity called post-colonoscopy syndrome. This is very rare, but it's where people kind of think that they got persistent pain and distension after a colonoscopy. There's nothing much to do about it. You just keep fluids in, observe, treat the symptoms, and it gets better with time. So very safe overall procedure. Special considerations: if you have an incomplete prep, the prep is poor, which is all that yummy stuff you have to drink. It means that the colonic walls are still covered in stool and they can't see anything. You usually have to repeat your colonoscopy within the year. All right. If it's an incomplete exam, meaning they can't get to the cecum, they can't get far enough, sometimes you have to do either a repeat or additional imaging to try to see all the way to the cecum. And then if they're young onset colorectal cancer, if you're young and you get cancer, right, we have this rising incidence. You got to really keep an eye for alarm symptoms. So if you have someone in your family who got colorectal cancer at a young age, really make sure you keep an eye on symptoms, bleeding, weight loss, all that kind of stuff. There are some alternatives to screening colonoscopies. The first is fecal immunochemical test, or the FIT test. This is where you actually send a sample of your stool. You have to do it annually, and if it's positive, then you still need a colonoscopy. But if it's negative, there's some suggestion that you don't need a colonoscopy. There's also Cologuard. You've probably seen commercials for this. This is another stool test that you have to send in. You have to do it every 3 years. That actually looks for DNA, and if it's positive, you might need a colonoscopy. There's special CT scans, CAT scans, called CT colonography that you can do every 5 years if they're positive colonoscopy. And then flexible sigmoidoscopy. This one you have to often combine with a FIT test. And this just looks at the sigmoid in the colon, the left side of your colon. And if it's positive, you might need some more advanced. So a lot of these are trying to, quote unquote, avoid colonoscopy. But with all of them, if they're positive, you still need the colonoscopy. Okay? Clinical pearls, prep is key. You need a good prep to get effective screening. So as terrible as it is, drink it. Withdrawal time matters, where they're pulling the scope out. You want this low and slow so that you can make sure to see all the walls. Adenoma detection rate, you want at least 25% overall. Polyp documentation is important to know where the polyp is, what it looks like, what was done about it. And then shared decision making with patients to make sure that the things you're doing are what the patients want you to be doing. So summary, colonoscopy is the gold standard for colorectal cancer screening. There are alternatives, but colonoscopy is the gold standard. It has diagnostic and therapeutic capabilities, right? You can resect and get rid of the polyps before they become cancerous. A couple different guidelines. More screening with younger, procedural technique, post-polypectomy management is essential to optimize all this and reduce colorectal cancer burden. Colonoscopies are proven to be preventative for colorectal cancer. So everybody get your colonoscopies. That's what we got for you today. Let us know what thoughts, comments, questions you have. Check out that Patreon page, weekly newsletter, all that good stuff. And either way, stay well, keep learning, and we'll see you all next time. WhiteBoard Medicine. We appreciate you checking out the video. Here at WhiteBoard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.